There is a hormonal transition happening in the bodies of tens of millions of American men over the age of 55 that is simultaneously affecting their energy, their muscle mass, their body composition, their bone density, their cardiovascular health, their cognitive function, their mood, their metabolic regulation, and their sexual health. And the majority of those men have never once had a direct, comprehensive, medically thorough conversation about it with their physician. Not because the condition is rare, it is extraordinarily common. Not because the science is uncertain. The hormonal physiology of male aging is one of the most extensively researched areas in geriatric medicine. And not because the clinical consequences are trivial. They are anything but. It is because the symptoms of declining testosterone in the aging male are so gradual in their onset, so easily attributed to unrelated causes, and so deeply intertwined with the cultural narrative of what aging in a man is supposed to look like, that millions of men spend years, sometimes decades, experiencing the cumulative physiological consequences of significant androgen deficiency without ever connecting those consequences to their actual cause. The fatigue they attribute to a demanding schedule, the loss of muscle mass they attribute to reduced exercise time, the increasing abdominal fat they attribute to dietary changes, the declining cognitive sharpness they attribute to the normal dulling of aging. The mood changes, the reduced motivation, the diminished sense of drive and purpose, all attributed to the psychological adjustments of a life phase, to stress, to the accumulating pressures of the years. None of these attributions are necessarily wrong, many of them are partially correct, but all of them are incomplete, because they fail to account for the specific hormonal substrate in which all of these changes are occurring, and whose normalization represents one of the most clinically meaningful and most underutilized opportunities in the preventive health of American men over 55. Today, we are going to have the complete conversation. Hello everyone, welcome back to Dr. Core Health. What we are covering today is one of the most consequential and most inadequately addressed hormonal changes in the aging male body. The progressive decline in testosterone that begins in the 30s, accelerates through the 50s and 60s, and produces a constellation of clinical consequences that profoundly affect quality of life, metabolic health, cardiovascular risk, and cognitive function in a majority of men over the age of 55. This is going to be a thorough, honest, and medically complete conversation, covering the physiology of testosterone decline, the full clinical picture of its consequences, the diagnostic evaluation that every affected man deserves, and the complete treatment landscape that extends far beyond the simplistic narratives that typically dominate this topic in popular media. Subscribe if you are new here. Let us begin. To understand why testosterone decline after 55 produces such a broad and consequential constellation of symptoms, we need to begin with a clear understanding of what testosterone actually does in the male body. Because the answer extends far beyond the reproductive and sexual functions most commonly associated with this hormone in popular understanding. Testosterone is the primary androgen male sex hormone, produced predominantly by the Leydig cells of the testes, under the regulatory control of the hypothalamic pituitary gonadal axis. The hypothalamus releases gonadotropin-releasing hormone in a pulsatile pattern, stimulating the anterior pituitary to release luteinizing hormone and follicle-stimulating hormone. Luteinizing hormone stimulates the Leydig cells to synthesize and secrete testosterone, and testosterone, circulating in the bloodstream, exerts negative feedback on both the hypothalamus and the pituitary, regulating its own production through this closed-loop hormonal system. In healthy young adult men, total testosterone levels typically range between 300 and 1,000 nanograms per deciliter, with a pronounced diurnal variation. Peak levels occurring in the early morning hours between 7 and 10, declining by approximately 25 to 50% across the day to reach their nadir in the evening hours. This diurnal variation, clinically important for accurate measurement, progressively diminishes with age, with older men demonstrating a significantly flattened daily testosterone curve. Beginning around the age of 30, testosterone production declines at a rate of approximately 1 to 2% per year in the average male. A gradual, continuous, and entirely physiological process that reflects both a primary testicular component and a secondary hypothalamic pituitary component. The primary testicular component involves an age-related reduction in the number and function of Leydig cells, the testicular cells responsible for testosterone synthesis. This Leydig cell decline is driven by oxidative stress, mitochondrial dysfunction, and reduced sensitivity to luteinizing hormone stimulation within the testicular tissue itself. The secondary hypothalamic pituitary component involves age-related changes in the pulsatile release of gonadotropin-releasing hormone, with reduced pulse amplitude and altered pulse frequency contributing to reduced downstream luteinizing hormone secretion and consequently reduced testicular stimulation. Superimposed on this gradual biological decline are several age-related factors that substantially amplify testosterone deficiency in many men over 55. The first is sex hormone-binding globulin elevation. Sex hormone-binding globulin, a protein produced by the liver that binds testosterone in the bloodstream and renders it biologically inactive, increases at approximately 1 to 2% per year with aging. This means that even when total testosterone remains within the statistical normal range, the biologically active free testosterone fraction, the testosterone not bound to sex hormone-binding globulin and therefore available to interact with androgen receptors in target tissues, those may be significantly deficient. This is why a clinical assessment of testosterone status in a man over 55 that measures only total testosterone is incomplete. The clinical picture can only be fully evaluated with simultaneous measurement of sex hormone-binding globulin or free testosterone, because it is the free and bioavailable testosterone fraction that determines androgenic activity at the tissue level. The second amplifying factor is visceral obesity. As established in our previous video on belly fat accumulation after 55, visceral adipose tissue expresses high levels of the enzyme aromatase, which converts testosterone to estradiol, the primary estrogen. In men with significant visceral fat accumulation, this peripheral aromatization removes testosterone from circulation at an accelerated rate, simultaneously reducing testosterone levels and elevating estradiol levels, a hormonal ratio disruption that compounds the clinical consequences of age-related testosterone decline. The third amplifying factor is chronic systemic illness. Conditions that are substantially more prevalent after 55, including type 2 diabetes, metabolic syndrome, obstructive sleep apnea, chronic kidney disease, and chronic inflammatory conditions, all suppress the hypothalamic pituitary gonadal axis through mechanisms including elevated inflammatory cytokines, elevated cortisol, and the direct suppressive effects of specific disease processes on gonadotropin secretion. This means that the clinical testosterone deficiency experienced by many men over 55 is not purely a consequence of normal aging. It is the compound result of aging biology operating in the context of concurrent medical conditions that each independently suppress testosterone production. The clinical presentation of testosterone deficiency in men over 55 is not the simple, easily recognizable picture that most public health messaging suggests. It is a complex, multi-system constellation of symptoms, many of which are subtle, gradually progressive, and easily attributed to unrelated causes, that collectively represent one of the most clinically important and most frequently missed diagnostic pictures in geriatric male health. Let me walk through 13 specific symptoms that most men are experiencing, normalizing, and never connecting to their hormonal status. Symptom 1. Persistent fatigue and reduced energy. This is the most universally reported and most universally dismissed symptom of testosterone deficiency in the older male population. Not the tiredness of physical exertion, not the sleepiness of a poor night's sleep. A pervasive cellular-level reduction in vitality that makes previously manageable activities feel disproportionately effortful, that reduces the capacity for sustained physical and mental engagement across the day, and that resists improvement despite adequate sleep, adequate nutrition, and the absence of obvious explanatory medical conditions. Testosterone exerts direct effects on mitochondrial biogenesis and function, the cellular machinery of energy production, in muscle cells and throughout the body. It promotes the production of red blood cells through stimulation of erythropoietin secretion, increasing the oxygen-carrying capacity of the blood, and it maintains the anabolic hormonal environment that supports cellular energy metabolism. Testosterone deficiency impairs all of these mechanisms, producing a genuinely biological fatigue that is not resolvable through behavioral interventions alone. Symptom 2. Loss of muscle mass and strength. The progressive loss of muscle mass that accompanies aging, sarcopenia, is substantially accelerated by testosterone deficiency. Testosterone is the primary anabolic hormone maintaining muscle protein synthesis rates in adult men, and it exerts this effect through androgen receptor-mediated stimulation of muscle fiber hypertrophy, through promotion of satellite cell activity, the muscle stem cells responsible for repair and growth, and through suppression of the catabolic processes that break down muscle protein. Men with testosterone deficiency lose muscle mass at a rate significantly exceeding that of age-matched eugonatal men, and the functional consequences include not only reduced strength and physical capacity, but also the metabolic consequences of reduced muscle mass discussed extensively in our previous video on belly fat accumulation, including reduced resting metabolic rate, impaired glucose disposal, and worsened insulin resistance. The muscle loss of testosterone deficiency is not simply an aesthetic concern. It is a metabolic and functional deterioration whose downstream consequences include increased fall risk, reduced functional independence, worsened cardiometabolic risk, and accelerated progression toward the sarcopenic obese body composition that characterizes the most metabolically and cardiovascularly vulnerable profile in the older male population. Symptom 3. Increasing abdominal fat. The relationship between testosterone deficiency and visceral fat accumulation is bidirectional, which is precisely what makes it so clinically consequential and so self-perpetuating. Testosterone deficiency promotes visceral fat accumulation through its loss of suppressive effects on lipoprotein lipase activity in visceral fat depots, through its loss of direct inhibitory effects on adipocyte differentiation in the visceral compartment, and through its contribution to the insulin resistance and hyperinsulinemia that create the metabolic environment most permissive of visceral fat deposition. And as visceral fat accumulates, elevating aromatase activity and converting increasing proportions of the remaining testosterone to estradiol, testosterone levels fall further, creating a progressive, self-reinforcing cycle of decreasing testosterone and increasing visceral adiposity that accelerates body composition deterioration with each passing year. This cycle is one of the central reasons why the belly fat accumulation of men over 55 is so resistant to conventional dietary and exercise interventions, because the underlying hormonal environment driving the visceral fat deposition is not being addressed by those interventions. Symptom 4. Reduced bone density. This symptom is almost never discussed in the context of male testosterone deficiency, because osteoporosis has been culturally constructed as a female health concern. But testosterone deficiency is the most common endocrine cause of male osteoporosis, and hip fracture in men over 65 carries a mortality rate within 1 year of approximately 30%, substantially higher than the equivalent figure in women. Testosterone supports bone density in men through both direct androgen receptor-mediated effects on osteoblast activity and osteoclast suppression, and through its peripheral aromatization to estradiol, which is, paradoxically, the primary sex hormone regulating bone resorption in men as well as women. The decline in both testosterone and its aromatized product estradiol in older men with testosterone deficiency creates a hormonal environment highly conducive to progressive bone loss. Men over 55 with testosterone deficiency should be specifically evaluated for bone density using dual-energy X-ray absorptiometry, the same bone density measurement tool used for postmenopausal women, and the management of their testosterone deficiency should explicitly include bone health as a clinical endpoint alongside the more commonly discussed metabolic and sexual health endpoints. Symptom 5. Cognitive changes. The cognitive changes of testosterone deficiency are among the subtlest, the most gradually progressive, and the most consequential of the symptoms most men normalize as aging. Testosterone receptors are densely expressed throughout the hippocampus and prefrontal cortex, the brain regions most specifically responsible for episodic memory and executive function respectively. Testosterone supports synaptic plasticity in these regions, promotes the expression of neurotrophic factors including brain-derived neurotrophic factor, and exerts direct neuroprotective effects against the oxidative stress and inflammatory processes that drive age-related cognitive decline. Low testosterone levels are independently associated with worse performance on standardized tests of verbal memory, spatial ability, processing speed, and executive function in men over 55, after controlling for age, cardiovascular risk factors, and other potential confounders. And several prospective cohort studies have documented an association between lower testosterone levels and increased risk of mild cognitive impairment and Alzheimer's disease, consistent with the mechanistic data supporting testosterone's neuroprotective role. The man who attributes his increasing difficulty with word retrieval, his reduced multitasking capacity, his slower processing speed to simply getting older may be experiencing the specific cognitive signature of testosterone deficiency. A signature that is, to a meaningful degree, reversible with appropriate hormonal normalization. Symptom 6. Mood changes and reduced motivation. Testosterone has direct and well-documented effects on multiple aspects of psychological well-being, including mood regulation, motivation, confidence, competitive drive, and the sense of purpose and engagement that defines psychological vitality in men. The mood changes of testosterone deficiency are frequently characterized as a specific pattern, distinct from the anhedonia and persistent sadness of major depressive disorder, that includes increased irritability, reduced frustration tolerance, diminished motivation and initiative, reduced engagement with previously pleasurable activities, and a pervasive sense of reduced drive and purpose that men frequently describe as a loss of the quality that made them feel like themselves. The relationship between testosterone deficiency and depressive symptoms is bidirectional, with testosterone deficiency producing a depressive symptom pattern through its direct neurochemical effects on serotonergic and dopaminergic systems, and with depression itself suppressing the hypothalamic pituitary gonadal axis and further reducing testosterone production. Treating depression in a man with unrecognized testosterone deficiency with selective serotonin reuptake inhibitors, which further suppress testosterone through their effects on the hypothalamic pituitary gonadal axis and which independently impair sexual function, without addressing the underlying hormonal contributor, is one of the most common and most consequential therapeutic errors in the management of male mood disorders over 55. Symptom 7. Sleep disturbances. Testosterone exerts specific and measurable effects on sleep architecture, particularly on slow-wave sleep, the deepest and most physically restorative stage of non-REM sleep discussed extensively in our previous video. Testosterone deficiency is associated with reduced slow-wave sleep proportion, increased sleep fragmentation, and in men with concurrent visceral obesity, worsened obstructive sleep apnea through its effects on upper airway muscle tone. The bidirectional relationship between testosterone and sleep quality creates a self-reinforcing cycle that is clinically important. Testosterone deficiency impairs sleep quality, and impaired sleep quality, particularly inadequate slow-wave sleep, impairs the pulsatile growth hormone and testosterone secretion that occurs predominantly during slow-wave sleep. Symptom 8. Hot flashes and night sweats. This symptom is perhaps the most surprising to men, because its association with hormonal change has been almost entirely framed in the context of female menopause in popular health culture. But vasomotor symptoms, episodic sensations of intense heat, flushing, and sweating, occur in a meaningful proportion of men with significant testosterone deficiency, driven by the same hypothalamic thermoregulatory dysregulation that produces menopausal hot flashes in women, now occurring in men in the context of androgen withdrawal. These vasomotor symptoms are specifically associated with abrupt testosterone decline, such as that produced by androgen deprivation therapy for prostate cancer, but also occur in men with gradually progressive testosterone deficiency whose decline has been sufficiently pronounced. Many men experiencing episodic nocturnal sweating and daytime flushing in the context of other testosterone deficiency symptoms have never been offered a hormonal explanation for these experiences, attributing them instead to idiopathic vasomotor phenomena or to the side effects of other medications. Symptom 9. Anemia. This is perhaps the most under-recognized systemic consequence of testosterone deficiency, and one whose clinical significance extends substantially beyond the common complaints of fatigue and reduced exercise tolerance it produces. Testosterone stimulates erythropoietin production, the hormonal signal responsible for driving red blood cell production in the bone marrow. In testosterone-deficient men, erythropoietin stimulation is reduced, producing a mild normocytic normochromic anemia, a reduction in red blood cell count and hemoglobin concentration that is frequently identified on routine complete blood count without any recognized connection to the underlying hormonal status. The anemia of testosterone deficiency contributes meaningfully to the fatigue, reduced exercise capacity, and cognitive impairment experienced by affected men, and it is both a consequence of testosterone deficiency and a contributor to the functional decline that accompanies it. Symptom 10. Increased cardiovascular risk. The relationship between testosterone deficiency and cardiovascular risk in men is complex, clinically important, and frequently misrepresented in both popular media and even in some clinical practice. Multiple large epidemiological studies have demonstrated that men with lower testosterone levels have higher rates of cardiovascular events, cardiovascular mortality, and all-cause mortality, independent of traditional cardiovascular risk factors including age, hypertension, diabetes, and smoking history. The mechanistic basis for this relationship includes testosterone's direct effects on endothelial function, supporting nitric oxide production and maintaining vascular smooth muscle relaxation through mechanisms parallel to those discussed in our video on erectile dysfunction. Testosterone's anti-inflammatory effects on the vascular endothelium, its effects on lipid metabolism, with testosterone deficiency associated with the dyslipidemic pattern of elevated triglycerides, reduced HDL cholesterol, and an increased proportion of small dense LDL particles most strongly associated with cardiovascular risk, and its direct effects on cardiac muscle function, with androgen receptors expressed in cardiac myocytes and testosterone supporting normal cardiac contractile function. Symptom 11. Metabolic dysfunction. Testosterone is a direct regulator of insulin sensitivity and glucose metabolism in men, through mechanisms that include the promotion of glucose transporter expression and activity in skeletal muscle, the suppression of visceral fat accumulation and its downstream inflammatory and metabolic consequences, and the direct inhibitory effects of androgens on hepatic glucose production. Men with testosterone deficiency have measurably worse insulin sensitivity than age-matched eugonatal men, and the prevalence of metabolic syndrome and type 2 diabetes is substantially higher in hypogonatal men after controlling for age, body mass index, and other potential confounders. This metabolic relationship creates a direct clinical connection between the testosterone deficiency of aging men, the visceral fat accumulation discussed in our previous video, and the metabolic warning signs discussed in our diabetes video. All of these clinical presentations being manifestations of a shared underlying hormonal and metabolic dysregulation, whose comprehensive management requires attention to the hormonal substrate, not merely the metabolic markers in isolation. Symptom 12. Reduced exercise capacity. Beyond the muscle mass loss discussed earlier, testosterone deficiency impairs exercise capacity through multiple additional mechanisms, including the anemia-related reduction in oxygen-carrying capacity, the impairment of mitochondrial function and oxidative phosphorylation efficiency in exercising muscle, the reduction in cardiac output and myocardial contractile reserve, and the neurological effects of testosterone deficiency on motor neuron excitability and neuromuscular coordination. Men who notice a progressive and unexplained reduction in their exercise tolerance, the ability to sustain a given intensity of physical activity for a given duration, that exceeds what can be accounted for by reduced training frequency or concurrent illness, should include testosterone status in the clinical evaluation of this decline. Symptom 13. Reduced libido and sexual function. This is the symptom most commonly associated with testosterone deficiency in popular awareness, and yet it is frequently the last symptom that men report to their physician because the cultural associations of sexual function with masculinity and personal adequacy create a profound barrier to voluntary disclosure in the clinical setting. Testosterone is the primary hormonal driver of libido, the motivational drive toward sexual activity, in men. It is not the only determinant of erectile function, as established in our extensive video on erectile dysfunction, where we discussed the vascular, neurological, and psychological contributors to erectile physiology in detail. But it is a critical modulator of both the central arousal that initiates the erection cascade and the peripheral androgenic support of the cavernous smooth muscle and endothelium that underlies the mechanical capacity for erection. Reduced libido, in isolation or in combination with the erection changes discussed in our previous video, is a clinical indication for testosterone evaluation that should not require the physician to ask about it. It should be volunteered as the clinically relevant information it is. The clinical diagnosis of testosterone deficiency, formally called hypogonadism in the medical literature, requires the combination of two elements that are both necessary and neither is sufficient alone. The first element is clinical symptoms, the presence of one or more of the symptoms discussed in the previous section, occurring with sufficient frequency, severity, and temporal consistency to represent a meaningful change from the individual's historical baseline. The second element is biochemical confirmation, laboratory documentation of testosterone levels below the threshold consistent with normal androgenic function. Neither element alone is sufficient. Symptoms without biochemical confirmation may reflect other causes. Biochemical testosterone deficiency without symptoms does not require treatment. The clinical diagnosis requires both. The biochemical evaluation of testosterone status in a man over 55 should follow a specific protocol that is more demanding than the single total testosterone measurement that constitutes the entirety of the hormonal evaluation in many clinical encounters. Total testosterone should be measured from a blood sample drawn in the morning between 7 and 11, when testosterone levels are at their daily peak due to the diurnal variation of the hypothalamic pituitary gonadal axis. An afternoon total testosterone measurement significantly underestimates true androgenic status and cannot be used for diagnostic purposes. If total testosterone falls below 300 nanograms per deciliter, or if symptoms are present despite a total testosterone in the low normal range, the evaluation should proceed to measurement of sex hormone-binding globulin, allowing calculation of free testosterone and bioavailable testosterone, which provide the clinically most relevant assessment of the androgenic activity available at the tissue level. Luteinizing hormone and follicle-stimulating hormone should be measured to distinguish between primary hypogonadism, in which testosterone deficiency results from primary testicular failure, reflected in elevated luteinizing hormone and follicle-stimulating hormone as the pituitary attempts to stimulate inadequate testicular production (SAO), and secondary hypogonadism, in which the deficiency results from inadequate pituitary stimulation, reflected in low or inappropriately normal luteinizing hormone and follicle-stimulating hormone despite low testosterone. This distinction has direct therapeutic implications, because secondary hypogonadism may be amenable to treatment with agents that stimulate the pituitary rather than directly replacing testosterone, and because certain causes of secondary hypogonadism, including pituitary tumors, hyperprolactinemia, and hemochromatosis, require specific diagnosis and treatment beyond testosterone replacement itself. Prolactin should be measured to screen for hyperprolactinemia. Elevated prolactin, which suppresses gonadotropin-releasing hormone release and consequently reduces luteinizing hormone and testosterone production. Prolactin elevation above 25 nanograms per milliliter warrants pituitary imaging to exclude a prolactinoma. Thyroid-stimulating hormone should be measured, given the established relationship between thyroid dysfunction and the hypothalamic pituitary gonadal axis, and the significant overlap between hypothyroidism symptoms and testosterone deficiency symptoms. Estradiol should be measured, particularly in men with significant visceral obesity, To assess the degree of peripheral aromatization converting testosterone to estradiol and to identify the high estradiol, low testosterone hormonal pattern that specifically characterizes the obese hypogonadal male and that may require specific therapeutic consideration. A complete blood count, assessing hemoglobin and hematocrit, screens for the anemia of testosterone deficiency discussed in the previous section and establishes the baseline hematocrit that must be monitored during testosterone replacement therapy. Prostate-specific antigen, the screening marker for prostate cancer, should be measured as part of the pre-treatment evaluation in any man over 55 in whom testosterone replacement is being considered, given the clinical importance of excluding active prostate cancer before initiating androgen replacement. Bone density assessment by dual-energy X-ray absorptiometry is appropriate in men with symptomatic testosterone deficiency, given the established relationship between testosterone deficiency and male osteoporosis, to identify pre-existing bone density reduction that would influence both the urgency of hormonal intervention and the need for additional bone-protective pharmacological measures. Before discussing testosterone replacement therapy specifically, it is essential to address the substantial body of evidence supporting lifestyle-based optimization of testosterone production, not as an alternative to hormonal evaluation and treatment when clinically indicated, but as a foundational component of the comprehensive approach to male hormonal health after 55 that should accompany any management strategy. Visceral fat reduction, achieved through the resistance training, dietary protein optimization, carbohydrate quality management, and sleep improvement strategies discussed in our previous videos, directly addresses one of the most powerful modifiable drivers of testosterone decline in this age group. The reduction of visceral fat reduces aromatase activity, reduces inflammatory cytokine-mediated suppression of the hypothalamic pituitary gonadal axis, reduces estradiol levels, and in multiple clinical studies has been shown to produce meaningful increases in free testosterone in men with obesity-related secondary hypogonadism, sometimes to a degree sufficient to resolve clinical symptoms without the need for exogenous testosterone replacement. Resistance training, beyond its effects on visceral fat and insulin sensitivity, exerts direct stimulatory effects on testosterone production through the acute hormonal response to heavy multi-joint exercise. Large muscle group exercises, squats, deadlifts, rows, presses, performed at appropriate intensities, produce significant acute elevations in testosterone and growth hormone during and immediately following the training session, and the chronic adaptation to consistent resistance training includes optimization of the hormonal environment supporting androgenic activity. Sleep optimization, as established in our previous video, directly supports the nocturnal testosterone secretion that contributes to the morning testosterone peak measured in clinical evaluation. Inadequate slow-wave sleep reduces the growth hormone pulses that are linked to testosterone secretion, and the cortisol elevation of sleep deprivation directly suppresses hypothalamic gonadotropin-releasing hormone release. Men who normalize their sleep architecture through the interventions discussed in our sleep video consistently demonstrate improvements in morning testosterone levels, independent of any other metabolic or lifestyle change. Zinc, an essential mineral with a specific and well-documented role in testosterone biosynthesis, is frequently marginally deficient in older adults due to age-related reductions in dietary absorption and increased urinary excretion. Correcting zinc deficiency through dietary sources or supplementation at physiological doses. Being mindful of the copper depletion risk of excessive zinc supplementation discussed in our first video on supplement safety, EKG supports optimal testosterone production through its role as a cofactor for the enzymes involved in androgen biosynthesis. Stress management, through whatever combination of mindfulness, social engagement, physical activity, and cognitive behavioral strategies is most accessible and sustainable, directly reduces the cortisol-mediated suppression of the hypothalamic pituitary gonadal axis that is one of the most pervasive and most under-addressed contributors to functional testosterone deficiency in men experiencing chronic psychological stress.